I'd like to thank you for joining us for this three-part CMEO briefcase series titled Best Practices for Applying Recent Clinical Trial Data and Individualized Treatment to Fight EDS and OSA. This is a three-part briefcase series. Today's briefcase is titled The Impact of OSA-Related EDS on Health-Related Quality of Life. Time for a wake-up call. Today's program is supported by an educational grant from Jazz Pharmaceuticals. I am the president of Bogan Sleep Consultants, as well as an associate clinical professor at both the University of South Carolina School of Medicine in Columbia, South Carolina, and also the Medical University of South Carolina in Charleston, South Carolina. Joining me today is Dr. Terry Weaver, Dean Emerita and Professor Emerita of the Biobehavioral Nursing Science of the College of Nursing at the University of Illinois College of Medicine in Chicago, Illinois. She is also Professor Emerita of Nursing at the University of Pennsylvania in Philadelphia, Pennsylvania. Welcome, Terry.
Thank you very much, Rick.
It's exciting. I'm excited. You're one of the world's experts on quality of life measures, and this is going to be a great discussion. We have a great case. And so to frame the discussion today, let me review our learning objective. Our goal is that after this CMEO briefcase, you will be able to recognize the impact and burden of obstructive sleep apnea-related excessive daytime sleepiness in patients, particularly in terms of their health-related quality of life and work productivity. So let's meet Margaret. She's a 35-year-old female who's been diagnosed with moderate obstructive sleep apnea. She has had a previous sleep study performed that showed an AHI of about 26 episodes per hour and nadir O2 sat of 82%. On presentation, her Epworth score was about 15, and she had loud snoring, frequent awakenings, but no trouble going back to sleep, at least 2 episodes of nocturia per night and some night sweats, typical symptoms of obstructive sleep apnea with residual daytime sleepiness despite adequate opportunity to sleep, but fragmented sleep and multiple awakenings. CPAP was initiated, and we elected to use an auto mode at a pressure of 7 to 12 centimeters. And we did do a download that showed 100% adherence with an AHI of 1.8, average use 7 hours. Her Epworth score is 13 on follow-up assessment, and her quality of life measure, the modified FOSQ, was 14. Snoring had been eliminated, at least by patient report, and occasionally she would work late for work, but in general had an adequate opportunity to initiate sleep and had a reasonable circadian rhythm. She caused 2 motor vehicle accidents in the last year, dozing off and drifting. And sometimes she's distracted with daydreaming during the day. She's had a gradual weight gain. Her BMI is 34. She has borderline hypertension. Interestingly, there is a family history of sleep apnea, and but she is married, but unable to socially commit to her husband and friends because when she gets home from work, she's pretty tired. She does feel some melancholia because she's tired, but is not clinically depressed. And she's on no medications other than oral contraceptives. So let's hear from Margaret herself. Hi, Margaret. How are you today?
Hi, Dr. Bogan. I'm okay.
That didn't sound very convincing. What's going on?
I'm okay. Okay, so when I first started seeing you, or coming to see you, it was because my husband had been complaining about me snoring. Now, he knew everybody in my family snores, even the babies. So it's never been an issue, but as of recent, it became a really big issue. And so that's when I came to see you. And I think I can't remember the name of the CPAP.
Yeah,
I've been
CPAP.
using that machine.
Right. Well, you know, what happens when you go to sleep is the brain is shutting everything down. All the muscles in your body relax. And when the muscles relax, you know, your heart rate drops, blood pressure drops, your body temperature drops, your muscles relax. But in you, the muscles in your throat that you use for speech and swallowing, they relax too much. That runs in families. They relax too much, they collapse and vibrate, but then sometimes they collapse and block off your airway, which we call sleep apnea. The CPAP is putting a little bit of pressure on those throat muscles and popping them open. So you shouldn't snore, and it should prevent you from holding your breath, and it should correct the oxygen levels and make it easy to breathe. So what do you think about the CPAP?
So yeah, I've been wearing it. It's comfortable. I am going to sleep. He said I'm not snoring.
Perfect. Okay.
But he is now complaining on a very consistent basis that I am quote unquote not present. So here we are meeting again per his recommendation. But I will say I sleep through the entire night and I still wake up and feel like I haven't slept at all. So I don't see how anyone can expect me to be present and I still feel tired.
Well, you know, there are some people who still have residual sleepiness. And when people are sleepy, they are tired. And sleepiness affects executive function, thinking, memory, focus, driving skills. I mean, when you do things that are monotonous, you might doze off. Have you had any problems with those?
Yeah, actually, I'm ashamed to say, it's funny you bring it up. I definitely fell asleep while I was driving. Actually, I don't think my eyelids closed though. Like I wish I had the right words to describe it. It's almost like I was in the zone, but I was zoned out, like almost on autopilot or like sleepwalking with your eyes open. I get into a daze, especially with anything that I repeatedly do. And then when you talked about, what do you call it? When you talked about executive function,
Right.
Work has been awful. Like to the point where I feel like I'm going to lose my job. I cannot concentrate.
Are you actually dozing off? Maybe drifting off?
I don't think it's drifting. Like I don't ever like feel like I just woke up. But then I guess I would have a moment where I feel alert. I actually kind of never feel alert.
Yeah. Well, you know, it's interesting because your download looks good. The CPAP is perfect. I mean, I think in terms of hours of use, we can always use more hours, obviously, but you're getting adequate hours. There's a good efficacy. We talked about that. But we do know that there are some people who are still sleepy, and you actually filled out your sleepy score, the Epworth score. My Epworth score is 6. Your Epworth score is very high, which is an indication that you do have residual sleepiness. Now, what we think happens in some people, we don't know, the exact percent is debatable, but somewhere around 30% of patients, despite using the CPAP in excess of 6 hours, still have residual daytime sleepiness. And of course, when you're sleepy, speed of processing, thinking, memory, motivation, all those are affected. And usually we have medication that we use to help out with that.
And you said we can't do anything else with the machine?
I think the machine is okay. But the medications, what they should do, what we think they do, they're not habit forming, usually well tolerated. They could have some side effects because they're activating the brain. They improve speed of processing, so you're more alert. And when you're more alert, you're more motivated and you can think faster and remember things, and hopefully will help with the driving. I'm worried about the drowsy driving because I don't want you to have an accident. But I can't remember, what other medicines are you taking?
Just birth control.
Okay.
Yeah.
Because that's important. That's important when we consider, you know, what medications we might use. But I really do think that we have something that's going to make you feel a lot better in terms of wakefulness promotion.
Okay. Well, Dr. Bogan, you already know, you're the man. My husband believes every word that comes out of your mouth. So I'm in agreement.
All right.
And I do, me personally, I trust you. So if you think that medication can help, then I'm on board.
I think we should try it. So Terry, unfortunately, it is not uncommon for CPAP compliant patients like Margaret to have persistent sleepiness, even if their chief complaint is not sleepiness itself. And I think that's interesting. Margaret was sort of like, I'm tired and I'm not motivated. She didn't really describe sleepiness. So what are some of the indicators of the impact of excessive sleepiness seen in these patients?
So despite having adequate CPAP treatment, many patients, Rick, really misattribute their sleepiness. They think it's due to something else. Sometimes they think the CPAP machine's not working. But a fair number of pulmonologists and sleep physicians do know that some of their patients still have what we're calling residual sleepiness, despite regular and optimal use of CPAP treatment. And this is something that really does need to be explored. As you saw with Margaret, she wasn't, she said she was getting restorative sleep, but she thought, well, maybe the CPAP machine isn't working. And because sleepiness is so pervasive, it's really difficult for them to say that it's due to one particular thing. So they just think it just is something that they're going to have to live with.
Yeah, it impresses me that patients come to us because they want to feel better. They don't feel good, and they also want to be healthy. They don't want to be sick or die. And oftentimes we focus on the CPAP. What's the AHI, how many hours you use it, but we don't necessarily focus on the impact of the sleepiness. And I know you've done some work as well as many others, and that's why we don't know exactly the prevalence of sleepiness, but it depends on the cohort. But I know you've done some work looking at the prevalence of persistent sleepiness and different ways to measure the impact of the sleepiness, of course, the Epworth score and the modified FOSQ, and of course the MSLT as well. Would you be willing to comment on the prevalence?
Yeah, it's running about 17 to 20% of patients. The problem is that that assumes we ask the questions about daytime sleepiness. And often when patients are on CPAP, we know that their adherence is good. We figure they're on auto control. We don't really need to explore that any further. And then yet, as we saw in Margaret's case, they're still suffering from depressed mood, melancholia, and also just not feeling very well. Mm-hmm. The sleepiness really affects everything that patients do. It's not only that they have problems with cognitive execution, cognitive processes, they also have problems, being able to perform at work, problems with concentration, problems with memory. They have difficulty sustaining attention, which is the concentration part, and that does lead to accidents. They also have difficulties in maintaining, and as Margaret did, social interactions because they fall asleep when they're at a friend's house. And of course, they're embarrassed by that. So they stay at home, or they just fall asleep in the evening, as you mentioned earlier. Patients have problems with their social interactions and their marital relations. They may be more irritable, and often these patients do have an effect on their relationships, and they don't engage in sexual activity because they're just too tired. They just plop into bed and go right to sleep. And this has an effect on marriage as well. And of course, consequently, divorce rates are prevalent in individuals with sleep apnea who are sleepy.
Yeah, in my clinic, when the patients come back, we typically do the Epworth score, and we also do the modified FOSQ. I don't know if I'm saying that right, but some people don't put the Q in there. But I mean, you develop that questionnaire, and I find those different domains really help us qualify and quantify. I mean, does the patient have some impairment, and how bad it is? Would you talk about domains impacted by excessive sleepiness and how those are quantified?
Yeah, absolutely. So the functional outcome of sleep questionnaire, known as I call it the FOSQ. There's a 10 item, although a lot of people call it the FOSQ. There's a 10 item version and a 30 item version, but the 10 item version is being used clinically. And it really does provide a quick assessment of the impact that's just beyond I'm sleepy and tired. And you know, the Epworth Sleepiness Score does really measure how sleepy an individual is, but the functional outcome of sleep questionnaire gives you the information about the impact of that sleepiness on the patient's daily behavior. So in addition to having difficulty with concentrating, like doing paperwork, they can't do paperwork, they can't get assignments done on time. Then there's memory. They you know, try to go to the store and they can't remember what it was that they went to get. And so those kinds of things. And then of course that causes problems in social interactions and also with marital, because they said, well, why didn't you remember what it was that you were supposed to do?
Right.
And of course they have trouble with driving. They have trouble driving long distances, some even short distances, and they fall asleep at red lights, stop signs. So that's a quick question one can ask, you know, do you fall asleep readily? And as I mentioned before, there's not a desire for sexual activity. And they have problem keeping up with others their own age and being as active as they want to be in the morning and sometimes even in the evening. And so it really has a profound impact on all aspects of their life, not just the brain fog.
Right. So, you know, and we've looked at some SF-36 data too, looking at physical domains as well as, you know, social and psychiatric domains that look at quantitatively how sleepiness affects individuals. Do you want to comment on, you know, the physical work and daily life quantitative data that might occur, as well as some of the emotional, psychosocial aspects that we might see on these scores?
Yeah, so as I said, you know, they just don't have the energy to fulfill their daily activities. And that includes just any physical exertion, the need to take naps, which actually may have been what brought them to the sleep professional to begin with, was because they were having to do that because they were sleepy prior to treatment. They fall asleep in social situations, they have a decrease in energy, and then they just can't get the work done. And that then creates more anxiety for them because then their performance declines. And, you know, they're at risk, as Margaret said, of being fired. And that's very troubling to them. And then, of course, the driving situation. Some even patients restrict their driving, so then they can't fulfill the needs that they have to get to either engage in social interactions or to go and get supplies and other things because they're afraid they're going to get in an accident. And Margaret's done that several times where she's had an accident. So it really does make it difficult to be able to have a normal life.
Well, you had mentioned the effect on mood as well. I mean, irritability and social interaction and some of that. And I mean, we clearly know there's changes in mood in individuals who are sleepy, and we also know that individuals who are depressed, who have untreated sleep apnea, it's more difficult to treat the depression. But would you comment on how mood is impacted by excessive sleepiness in patients with sleep apnea?
Yeah, it is really mood. It's not organic depression. So when we want to assess it, we want to keep that perspective in mind, and we wouldn't use an instrument like the Beck Depression instrument. We would use something that really focuses on mood. It's really, there's more emotional lability, irritability. As I said, they are on edge. They're quick to anger. Their frustration point is very low. They get easily frustrated. And so all of this makes it really difficult for them to engage socially as well. And you know, this isn't just something that's a side effect of being on CPAP, or we know, for example, that there are patients as I said, about 20% of patients who present with these problems and this of excessive daytime sleepiness. But in studies that I've done with my team, we have found that in fact, there is a physiologic reason for that. We have found using deep tensor imaging that there is white matter compromise in the brain with problems with the integrity of the myelin and the destruction of axons. So in fact, there's difficulty with neurotransmission because of the impact of sleep apnea on the brain. And of course, then that makes functioning difficult, and then the need to address that pharmaceutically.
Yeah, it sounds as though we have obviously subjective study data that shows persistent sleepiness in a certain group of these individuals, and as you pointed out, some evidence now of organicity here. But now that we have a better understanding of the prevalence and the fact that there is persistent sleepiness in some of our CPAP adherent patients, and how persistent the EDS can impact several domains of functioning, we have to be sure to effectively treat our patients, not only the obstructive apnea, but their symptoms. How would you recommend we follow these patients in terms of how do we measure their response?
Yeah, that's very important. I think it begins not only in the patient's part of awareness of that sleepiness is important, but also on the practitioner's awareness of that. And that is, once they're on CPAP, even though they're highly adherent, we want to ask the question about whether or not they're experiencing daytime sleepiness, because they may be. And if we don't ask, they also may not come and bring that up to the provider. In Margaret's case, her husband luckily urged her to seek treatment for this. As we've discussed, there's some very brief tools that can be very helpful. Certainly the Epworth Sleepiness Scale, which is an 8-item tool, measures the symptom of sleepiness. So that's a way to say, is sleepiness present or not? But to understand the impact of sleepiness on daily functioning, another brief tool, as we've mentioned, is the Functional Outcome of Sleep Questionnaire, which is only 10 items. So it only takes a couple minutes to complete that. And then that can be scored using an Excel file and tell you whether or not a patient is sleepy or not. And then there is the Patient Health Questionnaire 9, which is an assessment of mood, which again is a short, brief questionnaire that can be used. We know, for example, that Margaret's Epworth Sleepiness Scale was 13, which is indicative of daytime sleepiness, where a normal score is about 10. And then a Functional Outcome of Sleep Questionnaire of 14, which also indicates that sleepiness has had a real impact on daily functioning, quite profound, because the normal score there is about 17.84, so close to 18. So it shows that she has impaired daily functioning related to the daytime sleepiness.
Yeah, I like to use that scale because of the multiple domains. You can see people move from different domains in terms of how it impacts them in terms of their social interaction or driving or cognition, things like that. It's a very useful scale. And of course, we won't get into this, but obviously, as clinicians, we make sure nothing else is going on. I mean, sufficient sleep, no medical or psychiatric comorbidities that could explain the fatigue, and make sure they don't have narcolepsy, some other things. We won't actually get into that, but I think the important message, as you said, is there are some of these people, despite we've done everything we can do, they're adherent to CPAP, that they still have some functional impairment. So this has been a great discussion on the profound impact of EDS, even in patients adequately treated with CPAP. So let's summarize with our SMART, or specific, measurable, attainable, relevant, and timely goals. That is, what we hope our audience will take from this presentation and apply to their practice. We hope that our audience will recognize that EDS may persist despite adherence to CPAP, assess patients with OSA for persistent excessive daytime sleepiness, and have a heightened awareness of the impact of excessive daytime sleepiness on work, psychosocial, and cognitive function, as well as quality of life. So today's CMEO briefcase is part one of a three-part series of case-based activities that can be found on the Sleep Disorders Hub. I hope you'll check out the other two activities in the series that address strategies to individualize treatment planning for patients with OSA and applying clinical trial updates to optimize treatment decision-making. The Sleep Disorders Hub has these activities and many others on obstructive sleep apnea, excessive daytime sleepiness, narcolepsy, idiopathic hypersomnia, and more. I would like to encourage our audience to also visit the Sleep Disorders Hub for additional information, clinical guidelines, resources, and patient education about sleep disorders. To receive CME CE credit for this activity, participants must complete the post-test and evaluation online. Participants will be able to download and print their certificate immediately upon completion. So again, Terry, thank you for being on the faculty today and this very engaging discussions.
Thank you, Rick.
And I would like to thank you, our audience, for joining us. Be safe and take care of yourselves so you can provide the best care for your patients.